welcome. This is my version of the targeted iStent inject W procedure. I'd like to show a couple things I found useful. I'm going to skip right over the cataract surgery part and get to the interesting part here. So I purposely wanted to show the struggle that is probably part of all of these MIGS procedures. We don't talk about it very much, but you have to get the en face view, and you just finished with a cataract surgery many times, so they spend all this time telling the patient, look straight, and now you want them to look away, you want them to turn their head. You've got to angle the scope. Do not be afraid to really crank that dial, angle the scope, readjust your seat. You've got to do whatever it takes to get that view, and you can see me kind of doing all kinds of jostling here, and I'm doing different maneuvers with the scope, my chair, with their head. I've got to get a good view. So that looks pretty strong. Now you can see me mag up. I've got my light really bright. And this is what I'm looking for. These are the collector channels, the scleral spur. And you can see on the TM, that pigmented TM by the 2 stars, right behind it is a nice little blush. And that indicates you've got blood in Schlemm's canal, which is what you're looking for after cataract surgery, because that proves you have an open collector channel system in that area. So once we're sure we have a good view, now we got to settle. We've got to change the energy of the surgery completely. Just relax, hold a deep breath, get rid of everything, because the cataract surgery is done, but you've got to get that energy out and get into the angle space. Here we put in the device, make sure our view is good. I'm going to start magging up and release the sheath so we can expose the trocar. Now my targeting is going to be the collector channels that I showed earlier, and I like to go just anterior to scleral spur. I'll detail that more later, but here we go. I'm going to get a nice little dimple. I'm going to release the button, and then I try to pull straight back. There we go. Nice heme reflux. That's what I really like to see. When I see that heme reflux, that tells me I got a nice hit in the canal. Then this is so important. You've got to reposition the scope. I want to go straight on to the next collector channel. We don't want to use the same wound. Don't want to get overlocked. So again, we've got to release the first stent now. Everything is starting fresh. This is a second procedure. We can't use anything we've done to help us here. So I want to come in straight. I want to get a nice view again. Mag up. Release the protector sheath on the device, and then I'm going to show you the targeting again. There's a nice collector channel there, but look, it's a little fuzzy. I don't get great view. I finally realized this is on the eye's a little soft, so I'm going to stop, put in some viscoelastic, and note that I use the viscoelastic in my working area, not over the microstent. I don't want to put viscoelastic in the microstent. I want to keep it out. I want to let the aqueous get to it as quickly as possible. So now I've got a much nicer working area. I've got my collector channel identified, and we're going to go in for another try. Here we have a much better view, and I'm going to stop action this so that I can show you the targeting. There it is. So the collector channel is a really great one there. Scleral spur, there's my trocar. I am just anterior to scleral spur is where I'm trying to target. If I hit it just right, part of the flange will be over the scleral spur. There it is, nice blood reflux. That's exactly where I want to get this. And then I like to go in with the IA. I don't blow viscoelastic to make room for the view. I like to do it with the IA straight down over the device. That way I get the viscoelastic cleared out from the device and get a really nice view at the same time. So I'd like to show you this image from Chow et al. Really beautiful image showing the scleral spur. And look at the Schlemm's canal in relation to the scleral spur. That's what I'm trying to hit with the inject W. Here I'm going to show you a G1 device that is also in the canal really well with relationship to the scleral spur and a little old side pass. And then we put a G2 device on top to show same relationship with scleral spur canal with the G1 and the anatomy. So this is why I like to go just anterior to scleral spur. I think that's where the bulk of the canal is. here's proof of concept. Once you hit these stents properly, you'll see really nice reflux coming back at you. Look at the blush on the conch side there. So this is the goal I try to achieve for all of my microstents, G1s, Hydras, inject Ws. I want to see the heme coming back at me. This is very common day one. Don't panic. It's okay. You got to work the patient through it. That's hand motion vision. Give them 3 to 5 days, and they look like this. There was no treatment other than standard post-op drops. That clears out beautifully. A little bit of heme left. So, in summary, really work hard to get that on FOSS view. Don't rush that step. Locate the best collector channel, rotate the scope for the second stent, and I prefer just anterior to scleral spur. And that's my targeted iStent and inject W. Thank you very much.